Hi everyone, my name is Matt Walmsley. I'm one of the directors at Simply MSK and also the founder of Physio Off the Cuff. And today we talk about deloading and what that might look like for specifically the athletic population, but also the population that we serve more, which is more the generic population, people with comorbidities, etc. And I'm delighted to welcome Ellie Richardson, who we've got with us today, who is an athlete in her own right. She's performed for Scotland and Team GB in cycling, and she's also been an upper limb shoulder consultant physiotherapist for approximately the past 18 years. So she's got a really good wealth of knowledge in this field. So I'd like to welcome Ellie. Welcome. Right, hi Ellie, thank you for joining us, and thanks for taking my questions on this topic that we're going to talk about deloading this evening. Is that all right?
Yes, absolutely. Thank you, Matt. Thanks for having me.
No problem. So the reason that I asked you to join us tonight was just basically wanted to go through a concept that's familiar to me, but I wanted to go into it in a bit more depth. And with your background in elite sport as well, I wanted to get your thoughts on the deloading process. So what would you sort of explain to someone who doesn't understand deloading to them in the concept of an athletic background? How would you describe what a deloading is?
So, in a really simple terms, deloading or a deload week, I wouldn't necessarily use the word deload program. I'd probably say a deload week or a deload block. Um, it just involves reducing the intensity or the volume, sometimes both, in some way at the end of a hard training block so that you allow those physiological or mental, psychological, emotional, neural adaptations to take place before you start again. Bear in mind, when I think of deloading, obviously my background is in power sports or sprinting and athletics, sprinting and track cycling. It's all about maximal efforts going fast, hard, a lot of neural fatigue. So I'm not the best qualified to comment on it from an endurance perspective, but it tends to look different in that realm. But from a power sports perspective, for me as a woman, it usually involved at about week 5, I would have a week where I would half my volume but keep my intensity. Now, if anybody has any experience of training and training hard, like truly maximally, you can't keep doing that. You do that week on, week out. You start off quite fresh after you deload, and then you slowly dig yourself into a training hole, and you're ready for that deload week. And if you're a woman, and certainly for me as a female who has always been a type 2X athlete, I used to choose to keep the intensity exactly the same, but half the volume of my sessions. And I'd always come away from the actual discipline that I was doing. So you'd come off the track, you might do a little bit of road stuff if you wanted to, but you'd stay in the gym. So you're trying to maintain your power, your muscle mass, but you're reducing that volume so you freshen up. So my intensity, the maximum, what I was lifting would be the same, but my reps and sets would be halved, and I would move away from the track. If you're a man, quite often, because you hold on to muscle mass better than women, quite often it's the flip situation, but that is quite sports dependent. So quite often they will halve the intensity but keep the volume because they're better at recovering in the power sport sort of sprint realms. But in a nutshell, it's essentially giving you that week so those adaptations can happen. Otherwise, you will just sort of run yourself into a hole, and the physiological, the mental fatigue can be just too much. You just naturally need a rest. As also someone who when I was competing, I was an athlete who was always au naturel in terms of my sort of menstrual cycle and things too. So I tried to time my deload week to around about 4 or 5 as well, because that also tied in nicely with when my sex hormones would naturally plummet and when my power outputs would go down anyway. So from sort of day 2 to 5 or 6.
That's amazing. So there's lots of things that I want to kind of unpick from that I've not really come across before. So the first thing would be the volume and the intensity side of things and the difference from male and female. So would just looking at it from my perspective, the patients that I treat, it's not normally something that I'd take on board. But obviously talking at elite level, do you think that would be as much of a consideration if it was not quite as elite, but still looking at your return to sport person, patients that we've got?
Yeah, so I think it's sports dependent, and if you're working with populations and clinical populations who are aspiring to go back to high volume sports, then yes, no, I think it's a consideration. You do want to bear in mind that women do lose muscle mass quicker. So if you can keep at least the neural side going, you can even use things like wave loading and stuff, which we often don't do that much in physio if you're starting to rehab towards return to performance or return to participation. So I definitely would at that back end of rehab, try and keep the intensity a bit higher, but the recovery a bit more in those weeks where you think, actually, I want to make things a little bit easier. And then for men, they can get away with it a bit better. But in terms of clinical populations, I think if you're dealing with top end athletes, triathletes keep us very busy. They do 3 sports in 1 week, you know, or any powerlifters or strongmen or things like that. You know, the volume is generally very high, so you can extrapolate some of the performance principles a little bit easier. But with our clinical or painful populations, or if we're seeing people who aren't in the performance realm and you are wanting to try and sort of prescribe an exercise program to somebody, whether they're familiar with one or not, I think the concept of deloading probably is more applicable for them in terms of the other areas of their life. So when you choose to do it, because someone could be emotionally saturated with looking after their autistic child, or they could be having their house renovated, and so they've just not got their own time or space to do things. They're not sleeping well. I think we kind of need to take the principles of having that time off into those clinical populations, and not necessarily assume that more is better. As a profession, we seem to have swung. I mean, you know, I think we're old enough, both of us are old enough now to have seen swings in terms of pendulum swings, in terms of approaches and theories and mantras that we churn out. And I think at the moment we're very much in the, you know, do loads of strength training, push hard, keep going, rest is bad. We've almost demonized rest. I think we have moved towards a little bit towards demonizing rest, and I think that is a mistake, because often if we are prescribing exercise to someone who is saturated in other areas of their life, we are potentially doing something that is raising cortisol, that is adding to the demand of someone's picture, and that is very pro-inflammatory. And in those non-communicable diseases, that can not impact our outcomes in the way that we intend. So in the clinical populations, coming back to, I suppose, knowing the context of the patient is really important. And, you know, I think we probably all have, I know I certainly have had patients who've been from pillar to post, who are type A personalities. They are doing everything under the sun. They are full on with their kids. They go to work full time. They're high achievers. They're exercising. They're doing yoga. They've explored cupping. They've, you know, all these sorts of things. And you sit and listen to this, and you're almost quite stressed listening to it. And then you might say to someone, "Have you ever had a week off?" And they go, "No." And you know, there's been numerous patients where I've had that with, and I've said, "Go and have a week off. You know, you've tried loads of stuff. Just go and see. Just obviously you can't have a week off work, go to work. You can't have a week off your childcare, but have a week off exercise." And then I think sometimes it helps them to know my story, especially in that kind of patient group, where I can say, look, when I was an elite athlete, I had a week off quite often, you know, from my sport, and it's okay. The world's not going to end. Your muscles aren't going to suddenly fall off your muscles and run away. Fall off your limbs and run away. So people will go away and do that, and quite often come back in the right patient group and say, I feel loads better. Now, obviously, you're not then going to say, right, well, don't do anything for the rest of your life because it's making you sore. But it is used as part of an overall way of educating someone as to their whole lifestyle and what could be impacting their pain experience. And then, you know, you can obviously dissect it together then and work out how to get something fitted in a way that works for the patient.
That's fantastic. So one of the things that's one of my big bugbears is that we look at maybe the formative physiotherapists who are coming through, and they'll, you know, do a great job at taking subjective and objective history, and the prescription's the bit that's missing for me. So when they're at university, a lot of the therapeutic exercise side of things tends to get taught at MSc level. I mean, there's some good bits and pieces undergrad, but it tends to be more MSc level, and you tend to find this lazy pattern of 3 lots of 10 whatever TheraBand exercises and bits and pieces. And while that's, you know, we often wonder if we're seeing patients who are maybe more on the lazy side of the spectrum, or haven't been, so lazy is a really bad word to use there, but maybe have not been physically as active as they should have been, and we're trying to push that envelope, that we then tell them to do it daily. And it really strikes a chord when you're someone who's active yourself and you go to the gym, you do a chest, you know, a back day, leg day, and you might do a core day, but you'd have definite rest days in between. And we're telling these people who are not akin to exercise to go away and do it daily and do it, you know, repeatedly. And I do think that this whole ethos of deload is something we need to look at. And you emphasize quite a good point about the biopsychosocial side as well. And it's not just that physicality, it's thinking about them mentally as well, and what's their social situation. So it goes back again to taking a really good subjective and social history, which is brilliant. So You obviously, like myself, are interested or have a special interest in shoulders and elbow. So from a shoulder point of view, coming from a lower limb loading athlete, what sort of things have you taken from your experience to what you would do then from an upper limb patient that you might see, someone maybe who's struggling with either some kind of, I don't know, calcific tendinopathy or maybe a reactive tendinopathy or supraspinatus? How might you incorporate the deloading advice into someone like that?
So in clinical populations, obviously, you're not necessarily able to train someone. If there's pain present, it's unlikely that you're able to train someone in a truly maximal way. Whether you've got your handheld dynamometers out or not, the readings that you're getting for things, or you're on force frames or force plates in people with a history of pain or instability or apprehension or whatever, your reading that you get is not necessarily going to reflect their true maximum. So first of all, I suppose making the assumption that you're working on strength or you're working on that absolute maximum is perhaps not accurate in that population. So when you're not working someone truly maximally, and we hope to maybe get to that point with certain people depending on their goals, but if you're not generally working someone to peak force or generally working on rate of force development, all the rest of it, then you want these clinical populations to monitor their load themselves. And I generally use something like a traffic light system, but I don't use one, like you would for tendinopathies. I wouldn't use one thing for one person because, people understand different things. So I would make sure it resonated with them. But as a good place to start would be something like, right, you've not done this before. And let's say I've decided that pain is acceptable, because some things I don't want there to be pain at all. Some things we know that, let's say you've got an AC joint osteolysis. I don't want them to exercise into any pain. That's a no-go. But if someone's got rotator cuff related pain, then that might be absolutely fine and appropriate. So then I might say, imagine that when you're loading, we're thinking of a traffic light system where green is acceptable discomfort for you. And that's at the time, that night and the next day. Ideally, you're back to your baseline or similar. Amber's a bit, and red is I want to punch you in the nose. I don't want to do that again. I'm reaching for painkillers. That's what I would say. And then what I get them to do is ideally say, if you're in the green, that's good, especially if you're starting. If you're in the green on a session, do it 3 times over 7 to 8 days. And just make sure cumulatively you're still in the green, because we can always get away with a one-off and then we do it a few times and go, oh no, hang on. And see where you're sitting. If you're a bit amber, don't panic. Do the same thing. And if it comes back down to green, you've adapted. If it goes up to red, then it's perhaps an indication that we've done too much too soon. But it doesn't mean you've done any damage. It just means that that's some information about what your entry point is. I'm a big believer that everything has an entry point, an entry level in terms of rehab. So long as it's explicitly linked to someone's goals, you'll be able to eventually reverse engineer it. And I think it's really important in these atraumatic groups that you're sending people away with the tools to do that themselves, especially if they're not seeing you for 2 weeks. I will always say the worst thing you could do is go away and do everything I've prescribed as today, regardless as to your response, pain-wise, traffic light-wise, just because I told you to do it. That means I've failed to explain to you what we're trying to look for. With consistency is always key in that sort of population. So it's not until you get to that's introducing natural deloads there. If you use a traffic light, you're introducing natural deload days. And you'd very rarely do upper limb day every day in the gym if you were a bodybuilder or whatever anyway. You'd vary it. So it's a way of giving ownership to patients in those clinical populations. But hopefully, most of us will deal with people who are going back to top end sport. And quite often people do overtrain, and they don't perhaps understand that. Like my experience is, and I can talk at it from both sides, both of treating elite athletes and being one, was that the biggest difference between a top end amateur and a pro is that the pros rest a lot more. And I think it's quite powerful. And I think if it comes from a position, if someone's sitting in front of you, I'm quite lucky because they've quite often Googled me. And if they've sporty themselves, they've got a degree of faith that I have an understanding as to what it's like. So they will take what I say a little bit better. It's a bit like having the clinical specialist, logo on, it maybe unfairly sets you off on a better first foot than it would if you were a band 5, even if you were a really good communicator and a really, well-researched band 5. It can just offer that credibility, which I think increases buy-in with what you're trying to do.
Absolutely. So just looking at the whole picture then, do you feel like your sporting experience has changed how you would look at loading versus deloading a normal everyday patient?
So in patients that are more top end. So we obviously spoke before about thinking about the concepts of deloading in other areas of people's lives, whether that's possible or not, but thinking about how that contributes in within the context of the biopsychosocial model. But in those higher end patients, then I would, in those that have got less time, I think what I've learned through my time as an athlete in terms of utilising approaches like wave loading and manipulating reps, sets, recovery and load within a session. If you know you've got a certain number of reps that you want to get in per week, and you know that someone's got limited time to do that, but perhaps they're involved in a sport that requires them to tap into strength, power, speed, strength, endurance, you know, then you can use wave loading to address all of those at once. It can be a slightly quicker win. Obviously, it still takes, you know, it still takes time for those adaptations to happen. But you can utilize wave loading, and perhaps we don't do that enough. In terms of recoveries as well, I don't often hear that many physios talking about what recovery you should take between reps and sets. So let's say I've decided that someone is a shoulder patient and we've got their motor control back, which is, let's use instability as an example. So quite often we'll see both, especially internal rotation supported. If you were to draw it, it'd be like a wiggly line. You say you had a band in someone's hand, they're supported, and it would be quite wiggly compared to the other side, which might be quite nice and fluid. And that could happen early, but also late if you're seeing someone who's got full range, but has still got issues around the shoulder. And the same can apply externally. But let's say you've decided that, okay, actually cuff as a mover, in internal rotation is sort of the neuromuscular control's not there. You've worked on that, you've got it back, and it looks pretty symmetrical. Then obviously you can manipulate the resistance to see if that side-to-side difference is still there. And if you get to a point, I always say to patients that if you do get to a point where that looks really symmetrical and it feels easy and you kind of tick that box, we maybe want to try and look into the 8 to 10 rep realm, where by the time you get to reps 9 or 10, you've got maybe 1 or 2 reps in reserve. You're genuinely working quite hard, and if you can get to that point without pain or whatever, with good form, then you'd have 90 seconds, 2 minutes recovery between. But actually, if you feel like you've got other things limiting you, whether that's instability or pain or whatever, and you have to dial it back a bit, keep the recovery short, because we're not really actually making you stronger, we're just making you a little bit more stable. So I think it's understanding perhaps the mechanisms behind what you're doing once you've kind of cleared pain, of course, because that muddies the water in a lot of our outcome measures. As I said before, I think it's fraught to think that we are measuring true constructs of muscular performance in populations who have a history of apprehension or pain. I think that is a little bit fraught, but hopefully we get to a point where we can do that. And even then, in the absence of normative values for them pre-injury, assuming they're not a developing young adolescent athlete or whatever, then again that becomes a little bit more challenging, especially if you don't have a good arm or a good side to compare someone to. So I think we've just got to be a little bit honest about what we're working on and why. We quite often tell patients just get stronger, but if you think of like the force time curve generally, and you think you've got the rate at which you develop that force, then you've generally got a point in time where something happens, like either in lower limb world, you might call it a change of direction, or it could be, you go and you catch a child. There's a point at which a time constraint activity happens, and then past that, you've generally got your peak force. Sometimes, and that line there with the time is your impulse, essentially. So there to the left, the area under the curve is your impulse. So it's really probably more important the impulsivity of an athlete than it necessarily is generating a peak force, unless you're involved in someone where the two do actually come together. For example, like me coming out the starting gate, trying to put as much down as I can on the pedals. But most people, actually, the tasks happen around that. So there's a school of thought that suggests, we've gone off a bit off piste here, but there's a school of thought that suggests that you need to have peak force back before you even think about looking at reactivity or rate of force development. I'm not of that school of thought, for the reasons I've just said in terms of the force time curve. And I think you can get people moving quickly, safely, early, so long as you're pain-free. I don't think you always have to change the peak, because peaks quite often come back a little bit quicker as well. But I think there's often more to the clinical picture than that. So I think we can be more creative.
Absolutely. And you make some great points. And the thing about this whole topic, while we're trying to do like nuggets and bits of information, it's such a big one. And there's so many nuances and different things you've got to consider with the past medical history, the drug history, the comorbidities, the social side, the biopsychosocial issues. So, and it's good that even at the elite level that you're talking about, and your experience over 18, 19 years working as a consultant physio, we're still coming back to those basics, which is really sort of heartwarming as well from a physio point of view, because a lot of the things that I certainly implement are very similar along those lines. And you're trying to look at different things for different pathologies and say, right, well, am I adding hypertrophy here? Or am I actually just beginning to get you to move with less fear avoidance, or am I trying to add stability? And I think it's once you've got a mastery or a handle on those like pathologies, mechanisms, repetitive sort of patterns, that you can then add this next step to your practice. But I do think it's something that as a group of professionals, we need to be sort of looking inwards at ourselves as well as outwards to people like your sports therapists and higher level people who are like coaches in elite sport, and saying, am I challenging myself enough? Am I looking into the research enough to say what I'm going to give Mr. Jones is going to be different to what I'm giving to Mrs. Patterson? It's completely apples and pears, and you talk really fluidly about that, so that's really good. So I'm hoping that anyone listening tonight who's listened to the bits that we've talked about could take something away and be able to implement it in practice. So thank you for taking the time to speak to me.
No, you're very welcome. And the only other thing I was going to just, the other point I was going to make in relation to the very astute things that you're sort of picking up on is that I think quite often we'd be better off, with patients, they will be motivated or more motivated to do what you ask them to do if they understand the why behind it. And that's where your outcome measures should be explicitly linked to what you're doing. So patients shouldn't just go away going, I've got these to do, fingers crossed.
Yeah.
It'd be a bit like a coach telling you to do. I mean, it is old school. Back in the day, it would just be like, get on with it, off you go, and we hope you get faster. I remember going back to my athletics days, way back when up in Inverness, and I'd have, you'd be doing 8 lots of 200s with a jog 200 recovery. And me and my old training partners, like, we joke about it now, going, what were we working on? And then all of a sudden, I find myself in a British cycling setup where every bit of data is captured through your SRM on your bike, and every effort's downloaded, and you've got all the numbers, and you can see what's actually impacting what, and you actually see what actually there is science behind it, and there should be. And when it comes to our patients, if you've taken, let's say, most physios have their hands or a handheld dynamometer nowadays. Not everybody's got high-tech stuff. But let's say you are taking a measure, being quite clear to the patient, whether you're looking at for a loss of form or whether you're looking, if we just take that internal rotation measure, for example, and you fix the handheld on something, it could be peak force to pain, or pain, that would be what I would say, as opposed to your true peak force. So it could be peak to apprehension, and that's what I'd explain to them, because it might be a long time before they can give it full gas when they're doing that. So I think if they understand that this exercise is hopefully going to help that, which might help you with reaching your hand behind your back or reaching back or whatever, or throwing or whatever you're working on. And then the other stuff that you're giving might be more to do with setting the scene to get things warmed up and working a bit better. I think if we're explaining things, then patients are more likely to understand how to do them. And I will quite frequently prescribe different exercises. They won't, on different days. Some I'll be like, you can do this every day if you want, until the cows come home, because this is quite safe to do every day. But this one, if we're doing it in the way that we've spoken about, it could be genuinely fatiguing. And, if you're thinking about shoulder muscles, we know that it can take about 24 hours for the thickness of the cuff to go back to their normal resting length after a bout of load to fatigue. So you can apply judiciously, you can apply certain bits and pieces of evidence. But I think ultimately, sometimes some of that is more to get buy-in from the patient so that they're on board with what you're doing, and that they have trust in you, that you kind of have a good sound knowledge as to what's going on, and also their best interests at heart. But I think it does improve compliance and motivation for patients if they understand what their goals are too. If you get to a point where you're truly working on strength, it's important that you say to someone, look, it's going to be between 4 and 6 weeks before a parameter changes, if you're able to take a true strength parameter. And if it changes in 2 weeks, it probably wasn't strength. There might have been neural drive, but that's still a good thing, but it gives it a bit illuminating for us, and it maybe tells us what we want to do with reps and sets. And whether actually we just want to get you going a little bit more and get you more confident. So there's loads of things to it. And I don't think it's complicated. I actually think it's, when you sit down and talk to most physios, they probably think that themselves, but I think some people can get a bit hung up on, oh, right, I'm hypertrophying, so I'm doing this number of sets, or I'm in a power state, I'm doing this number. And that's why I suppose my recommendation would be for a lot of people to look into wave loading, because if you're unsure and you think about bang for your buck, then that could be a good thing to go and research and think, how could I apply that with the right patient at the right time?
Absolutely. One of the biggest nuggets I'm going to take away from tonight is the fact that we utilise the traffic light system like the Silvernagle article suggests, where you're looking at the red, amber, and green. And you've given what your explanation of that tonight was about the giving the patient the empowerment to go away and manage their own deloading time, and that's brilliant. That should be a headline of the talk tonight, because if you allow the patient to make that decision for themselves, you've done your job, because you've explained it and you've given them the tools to actually learn and cope with that pathology. And that's pretty much what we need to be doing, really, I think, in a nutshell. But then we've got all those other facets that you've mentioned that we can then implement as we go along. So brilliant. Yeah, thank you for that.
Don't be frightened to get people. Don't be frightened to say have some time off. I think that is something that we don't do, and we could do more. And equally, I think it's kind of like I said, the rest thing, demonizing rest. It's the blanket messages that are around that when we've got to take the person as a whole has almost happened in a similar way to, obviously I mentioned before about how I would time my deloading weeks to where I was in my menstrual cycle. I think we are falling into the trap as well with sound bites on social media in suggesting that it makes no difference, because we've got research studies that say actually people perform similarly across the board, and that's a danger too, because it is N=1 more than ever in those populations, and there's lots of unpublished research. I was lucky enough to be involved in or be aware of certain studies that were going on which certainly fitted with me and how I performed in a power sport throughout my sort of cycle. And there were huge differences. So I really object to these. I think it's well-intentioned meant in the sense of we don't want to make women fear avoidant. If you have a competition and you're on your period, you've got to be able to do something, that you don't want to be bummed out before you even start, even if physiologically you may be at a bit of a disadvantage if you're involved in a power sport. So it is a challenging one. But I think understanding where you can have those natural ebbs and flows, it is really important, because there are differences at different phases. Like if you're involved in a para sport, you'll generally, when your progesterone spikes, put out a higher peak. And then when everything flatlines, things do get more challenging if you're trying to work maximally. So quite often factoring in some recovery then. But I think that has been interpreted as, you're telling people to rest when they're on their period, you shouldn't do that. And I'm like, well, hang on a minute, that could be the right thing for some people to do. So I think that these messages, these blanket things, are usually really well-intentioned meant, but it's okay to rest. It's okay to rest the week of your period as well, and it's okay to ask these questions in within the context of clinical populations, because we're seeing a rise of these non-communicable diseases. And we know, so therefore in female populations, you're probably seeing a rise in things like endometriosis because of diet, lifestyle, the inflammatory components to people's pain. And we quite often don't, certainly maybe male physios don't. I will always ask about that, even if I'm not thinking at like Red S or something like that. I will always think about someone's menstrual cycle and the general diet and all the rest of it. Especially if you are thinking you are atraumatic, the elephant in the room for you is not a mechanical one,
Absolutely. Yeah, and it transits over to the hypermobile population as well, massively. And we see, and again, it's the N=1, so I'm being careful because more research is needed in this area, where you're finding that the person is unstable, but more unstable maybe at a certain point in their cycle with the progesterone levels. And then you think logically about how that would affect power output. And really, we're looking at the other end of the spectrum. When you've not got the power output or you've not got the motor control, that's going to increase that instability. So we do see this in a nuanced fashion, where we've got these sort of individual patients that are much more susceptible to hormonal changes. But thinking about it across the board is a must. We need to really start thinking about that in a step change way, really looking at that from a complete new way of assessing, really.
Yeah, and I think it kind of comes back to, I actually don't like the term "what's your philosophy." I've been asked for years "what's your philosophy," and it's always made me cringe. And I'm just like, go away. I don't want to. It feels rigid to say I have a philosophy. But actually, over the years, I've thought about it, and I think probably for me and for most physios, I think what we're trying to do is our philosophy is generally what's the elephant in the room at that moment, at that day, at that given time. Is it mechanical? Is it lifestyle? Is it external stresses? Can I change it? Can I not? Is it within my remit? What is the elephant in the room in this day? And you're honest about that to the patient. And the other is a cake. So I think elephants and cakes are my philosophy. So elephant, what's the elephant in the room? And the cake is, don't ice a cake that's not there. Let's not go to the fancy top end stuff if we've not got that, we've not addressed the elephant in the room and there is no cake.
Yeah.
That would be my philosophy, elephants and cakes. I'll write a book on it one day.
I'll come back to you on that one. We could collaborate on it. I'll do the elephants.
There you go. I do like
Perfect. I really appreciate your time. Thank you for taking the time to speak to me, especially in your own time, and it's been really, really useful. So hopefully it'll be the beginning of many meetings together. But it's really, really appreciated. So yeah, Ellie, thank you for your time.
Well, you're very welcome. Thanks for having me. My pleasure.
Perfect.